Welcome back to our session titled Aplastic Anemia and Non-Transplant Therapies. I'd like to welcome back with us Jacksonville and Rochester. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today.
Okay.
As we get started, I'd like to recognize the generous support of our corporate sponsors, Alexion, Apellis, Amogen, BioCrest, Bristol Myers Squibb, Genentech, Novartis, Regeneron, Servier, and Tahoe Oncology, and the generous support of the patients, families, and caregivers who support all of our programs in this conference today. Immediately following the presentation, there will be a question and answer session. If you're participating online, you can submit your questions using the Q&A icon on the right. All you need to do is type in your question and hit enter, and we'll be able to get to your questions today as well. If you're here in person and asking questions, let us bring the microphone to you so everyone will be able to hear your question, and it'll also be heard for those participating online. When asking your questions, I do ask that you do two things to help me manage the incoming questions. Submit your entire question all at the same time. And please don't share any health information in your question. Our expert today cannot answer any specific questions related to your personal health care. Our specialist today is Candido Rivera. Dr. Rivera is an assistant professor of medicine at the Mayo Clinic in Jacksonville, Florida. His research interests include homeostasis and thrombosis, bone marrow and stem cell transplantation, bone marrow failure syndromes, chronic leukemias, myeloproliferative disorders, and benign hematology. It's my pleasure to welcome Dr. Rivera from Jacksonville.
Immune-mediated aplastic anemia medical management, meaning not transplant approaches. Okay. So I'm going to put a few big words at the beginning, and then we're going to get down to the nitty-gritty. So we're going to talk a little bit about the pathophysiology of the disease, meaning I'm going to explain the mechanisms of why aplastic anemia, immunoaplastic anemia happens. And then I'm going to discuss upfront treatments, upfront medical treatments for acquired immune-mediated aplastic anemia. Historically, the first treatment that was available was anti-thymocyte globulin, which was developed in the 70s. Then cyclosporine was added to anti-thymocyte globulin in the late 80s. And within the past 10 years or so, triple therapy with the combination of ATG, cyclosporine, and L-Thrombopag has become the standard upfront care. I would also dabble into what to do on patients that have recurrent or refractory disease, and I'll talk about experience with alemtuzumab and danazol. As an introduction, I would also like to mention that I was fortunate to do my fellowship in hematology at the National Institute of Health, National Heart, Lung, and Blood Institute. So during my training, I dealt with hundreds of patients with aplastic anemia and paroxysmal nocturnal hemoglobinuria under the mentorship of Dr. Neil Young. And I was fortunate to work there for 5 years afterwards, which gave me a unique perspective in the management of patients with aplastic anemia. As you know, aplastic anemia is a disease that is rare, in 1 in 500,000 to 1 in 1 million. So somebody who has seen hundreds of patients, it's uncommon. So there's only going to be 2 other busy slides, and then I'm going to go to the nitty-gritty detail. So we're going to be talking about the top category. Again, acquired immunoplastic anemia, meaning you're not born with it, you acquire, your immune system turn against you. That's what we're going to be talking about today. But there are other causes of aplastic anemia that I'm just going to mention for reference purposes. Some people are born with a predisposition to get aplastic anemia, usually manifest in the young. Occasionally, it can manifest in young adults. And then we need to separate those from the patients with the acquired disease, as they will not respond to immunosuppression. Sometimes there are some patients that have a variant of myelodysplastic syndrome that has decreased cellularity and is sometimes difficult to distinguish from immune-mediated aplastic anemia, meaning hypocellular MDS. The good news, and as we discover at NIH, is that interestingly, patients with hypocellular MDS also respond to immune suppression with ATG and cyclosporine. And then it is after their response that we figure out that, oh, wait a second, what you had was MDS and not aplastic anemia. The lower ones are very uncommon, and eventually they declare themselves at some point as overt leukemia or lymphoma, but we're not going to be mentioning those at all. This is the last busy slide that I'm going to present. So as an intro, I'm going to be explaining each one of these sentences. So acquired aplastic anemia is an autoimmune disorder. It's acquired. You're not born with it. Your counts were normal before, in which your immune system turns against you and specifically is attacking your bone marrow stem cells, the ones that are responsible to proliferate and generate blood. If your bone marrow stem cells are destroyed, then you do not make blood. It's that simple. And then patients become dependent of either red cell transfusions, platelet transfusions, or their white count drops to dangerous levels. They do not have good immunity, and they're at very high risk of infections. Without treatment, if your bone marrow shuts down and you don't get blood transfusions, you don't get platelet transfusions, and you don't get the appropriate antibiotics to prevent infections, you're not going to do well. Fortunately, 50 years ago, the first treatments were developed, and ever since we have become pretty good at managing patients with aplastic anemia, and the great majority of patients get a response. So here we go. Hematology 101. You're going to get an honorary degree today, and you're going to be certified hematologists. Let's get into it. So your counts are low. What do we need to do to diagnose a patient? Well, you need a CBC. You look at the peripheral blood, but you're also going to need a bone marrow biopsy. When it comes to aplastic anemia, you have to go to the source. You have to see what's happening in the bone marrow space. This is non-negotiable. There's no other way around it. Now, in addition to looking at the bone marrow space, you can do certain things to reassure you that you have the right diagnosis. You request a bone marrow cytogenetics. What that means is that we're going to be looking at the genetic material of the bone marrow cells. We do a chromosome analysis. In aplastic anemia, the chromosome analysis should be normal, as opposed to in patients with leukemia or myelodysplastic syndromes. They have abnormalities that those bone marrow cells don't mature. We can do flow cytometry. This is just looking at the proteins in the surface of the cells. And these proteins in the surface can sometimes have specific patterns that can be predictors of a response. Specifically, some patients with aplastic anemia can have what we call a PNH clone. What's the significance of an aplastic anemia patient having a PNH clone? Answer. A PNH clone is able to escape the immune attack against the stem cells. Now, PNH cells are deficient in certain proteins, so they don't normally grow efficiently. So If we look hard enough, everybody has a PNH clone. It's just that it grows so inefficiently that it's very detectable. But when the normal cells are being destroyed by the immune attack, all of a sudden the PNH cells can get a growth advantage. And just the matter, they don't have to be in big numbers. They could be 1% of the total. But it gives you a hint that, oh, if you have a PNH clone, that means that your bone marrow is being subjected to autoimmune attack. Treating a small PNH clone doesn't help aplastic anemia patients, meaning with the current treatments to try to make the PNH clone cells survive. But there's going to be a whole talk about PNH later today, and they'll explain to you how that works. For the purpose of our discussion today, having a small PNH clones, all it means is that, yes, you're likely to respond to immune suppression. The last one in the bottom pertains more to young patients. Remember when I was telling you earlier that some young patients have an inherited predisposition to develop aplastic anemia? Those patients have a predisposition to get damaged stem cells that eventually will burn out and fail. Those patients will not respond to immune suppression. And it's important that we recognize them early. Fortunately, well, I don't see many of those patients because they are usually children younger than 20. Occasionally, there's somebody in their 20s, between 20 and 40, rarely somebody who's older than 40. All right. Now, let's start. What do we have here? A CVC. And this CVC is normal. This is my CVC from last month. I'm happy to report that my counts are normal. Well, let's digest this because I need to make sure that we all understand when I said normal, what normal means. Now, do you see in the top here, it talks about white cells. The white cells are the cells of immunity. And they are subdivided in 3 major subsets and 2 minor subsets that are at the bottom here. There are the neutrophils. There are the first line of defense against infection. If the neutrophils come down, you're at increased risk of infections, and that's a problem. The normal range is usually a number about 1.5 per liter. If sometimes these numbers are reported in per microliters. So if it was per microliter, it will be 1,000. If it's per liter, it will be 1.5. I just want to, because sometimes you have to pay attention to the units. In any case, I was fortunately normal. When the number starts getting below 1.5, yeah, that's out of the normal range, but not necessarily bad. When it drops below 1, you're at a slight increased risk of infections. When it drops below 0.5, you're at a very high risk of infections. When it approaches 0, it's a problem. It's a real problem. The other subsets are not as important in aplastic anemia, but I'm going to mention them. The lymphocytes, as I mentioned, are the ones that are the ones that are declaring mutiny. They are the ones that are attacking the stem cells. Monocytes have a function in the immune system to scavenge the debris that the neutrophils generate upon when the neutrophils first attack the bacteria. They generate pus. The monocytes analyze the pus and then bring it to the lymph nodes for the lymph nodes to analyze the debris and make antibodies. So in the future, you do not rely solely on the neutrophils, which are frontline soldiers, but you also have targeted missiles, meaning the antibodies. Lastly, the eosinophils and basophils, they're just noisemakers. They release histamine when you're exposed to an allergen. So all they do is release histamine to tell you, hey, withdraw from the ragweed, withdraw from the pollen, withdraw from whatever. But that's all they do. They don't really help us that much. This is a normal bone marrow biopsy. And no, that's not me. I only go so far when going to presentations. But what we see here is, you see those big round circles? That's fat. And then this pink, that's a bone, like that's a spongy bone. And then there are the cells. We always talk about what's the cellularity in the marrow? Why is that important? Well, in aplastic anemia, you have 0 or close to 0 cells. But how do I know if my cellularity is normal? Your cellularity should be 100 minus your age. So we can tell how old this person is. There's about 40 to 50% fat in here. So this person is probably 50 to 60 years old. 100 minus your age. See how that works? Now you're certified hematopathologist here. Now, this is a patient with aplastic anemia that I met a couple of years ago. As you can see, all of a sudden, there's a lot of red here. Now, let's start digesting these one by one. Remember, the total white count is low, and then we're going to look at the subsets. Here's the problem. Neutrophils, the absolute number, 0.1. This patient is at very severe risk of infection. Remember, less than 0.5, severe risk of infection. Between 0.5 and 1, moderate risk of infection. Above 1, you're sort of okay. I didn't dwell into these numbers here. Do you see these where it says percentages? Those numbers don't help you. Percentages are only used to calculate the absolute. So what that means is that 0.13 is 6.6% of the total white count, 2.0. See how that works? You only care about the absolute numbers, not percentages. It's the absolute numbers that have our convey function. Now, here's the platelet count. Those are the building blocks of a clot. Whenever the platelet count is below 30, you have an increased risk of bleeding. Below 10, you usually need platelet transfusions. As you can see, the normal range is pretty high, but you can go well below the normal range before you get into trouble. Now, let's talk about the hemoglobin. The hemoglobin can be reported as amount of protein. You can also see erythrocytes or red blood cell numbers, or you can report them as hematocrit. All these numbers are proportional to each other. So hemoglobin is just the protein that carries oxygen, which is inside of the red cells. The hematocrit is the fraction of cells compared to the plasma. So if you let the blood settle, the solid phase of the cells will be in the bottom and the plasma will be on top, and the fraction of the cells to the total is the hematocrit, the percentage. In any case, see how all these numbers go down? All these three will go in proportionally up or down at the same time. Whenever your hemoglobin is below 7, you're severely anemic, and more likely you will need a blood transfusion because you're going to feel bad, tired. When it drops below 10, yes, you're tired, but you don't quite need a blood transfusion. Most patients above 10 won't have any symptoms, even though it's below normal. Now, this is an aplastic marrow. As you can see, there's very few, if any, cells in there. This is like 5% cellularity or less. So it's either that or this person is 100 years old. That's the other possibility. They make fun of me when I used to read the bone marrow biopsies at NIH when you go to the meetings. because all the pathologists at the other institutions will say, well, you just read empty marrows. There's nothing to look at there. So, yeah. Now, here is a diagram of how the bone marrow cells mature. Up here are the stem cells. These are your friends. You need a lot of those because when these cells divide in the bone marrow, they can give rise to the platelet precursors. They can give rise to the red cell precursors. And here are all the white cell precursors. And as you can see, all these, as you can see in the yellow bar, these are inside of the bone marrow. And these are the ones that you see in the blood, the platelets, the red cells, the neutrophils, and you see lymphocytes too. Here they are, those are hard to read, so one more time, platelets, the building blocks of a clot, the red cells, the one that have hemoglobin in their inside and transport oxygen. Neutrophils, here's your first line of defense against infection. And here are the lymphocytes. The lymphocytes are categorized in two subsets. There are the B cells and the T cells. The B cells make antibodies, while the T cells are, you can call them special forces. They are not just frontline soldiers. They're very well-trained cells that can attack and destroy cells directly with specificity. The neutrophils, they don't really know what they're after. They just go. The lymphocytes are more subspecialized. Now, so what happens in immunoplastic anemia? Well, these are the T cells that turn against you, and they start attacking the stem cells. They are confused. Usually what happens, or the theory in general about immune disorders, autoimmune disorders, is that you're exposed to something, a virus, a bacteria. Your immune system attack and destroy that virus or bacteria, but then there was something in that virus or bacteria that resemble proteins in your stem cells. The T cells are confused, thinking that the stem cells are the bacteria, are the virus, or it doesn't have to be biological. It could be something in the environment that triggered the T cells. But the bottom line is the T cells are confused and they no longer understand that your stem cells are your friend. So they start attacking them. If you don't have stem cells, all the production line goes down. And that's what you're left with. Nothing. Just lymphocytes. But lymphocytes by themselves are not helpful. And that's what you see there. Aplastic, empty. All right. Patients, when this happens, some of them bleed because of the lack of platelets. Some become anemic. Some become anemic and bleed and infection. Some of them are picked up by a routine exam. The counts are low, but they're not low to make them symptomatic. Aplastic anemia patients otherwise tend to have no symptoms other than bleeding, tiredness, or predisposition to infections. If they have something else, if they have other symptoms, you have to look for something else. Now, these are the pathologic criteria for aplastic anemia. The amount of cells, or the cellularity, has to be less than 30%, but it's usually close to zero in the majority of patients. When you look at their blood, the absolute neutrophil count has to be severe. Remember, less than 0.5 or 500 per microliter. The platelet count has to be less than 20. They don't look at hemoglobin. They look at reticulocytes. And I didn't specify the reticulocytes. Let me put them in here. The reticulocytes are these guys here. They are one step below the mature cell. And it's important that we keep track of these guys because otherwise it's hard to tell if your red cells are being produced in the marrow. It will take time. The reason being is that once you make a red cell, that red cell will last 120 days, as opposed to a platelet that lives 5 to 7 days. A neutrophil just hangs around for 24, 48 hours. So if you have a red cell that lingers for 120 days, it's going to take you a long time for you to become anemia if the line of production is shut down. But if you monitor the reticulocytes, that gives you a more accurate measurement of how the production line is with the red cells. So let's go back to the diagnostic criteria. So if the reticulocyte is less than 60,000 per microliter, your red cells and the hemoglobin will predictably go down. And how do you know if your hemoglobin is going to come up? Answer: when your reticulocyte count goes above 60,000. So the neutrophils and platelets you tend to see right away. It's the red cells that take longer for them to come up. But they will come up if you see the reticulocyte number coming up. Questions are asked about what caused the problem. And to make a long story short, it doesn't matter what caused acquired aplastic anemia. At the end, the treatment is still the same. You need to move on with treatment. If once you exclude infection and all that, and that shouldn't take you that long, you need to move on. Otherwise, you're wasting time because stem cells are being destroyed every day. Here's the algorithm of how do you decide the treatment of adults. Once you meet the criteria, if you're fit and you're younger than 40 and you have a donor, transplant is preferred. If you're older than 40, if you don't have a donor, that's when we do the immunosuppression regimens. So here's the first one that was developed. The anti-thymocyte globulin, ATG. What is it? Well, essentially what they do is they take the thymus from a person. This is where the thymus is. And they put it in a horse. In the thymus, that's where the T cells are manufactured and programmed. So it's very rich in T cells. So you put them in a horse. The horse develops a lot of antibodies against the T cells. You extract the antibodies from a horse, and then you infuse them to a person. Once you infuse them to a person, then the T cells are destroyed, and you stop the attack against the stem cells. And the hope is that when you regenerate new T cells, those will no longer attack, that the new ones will not attack the stem cells. And that's how that works. There were a lot of controversies in the FDA about how you regulate that horse. That horse was pampered for a long time in a very nice barn and fed as you wouldn't believe. And there was concerns that what happens if the horse dies? Then do we need to standardize the whole manufacturing chain again? It didn't matter. When they did it from the second horse, it worked. Bone marrow stem cells will take, but the bone marrow cells were not well meshed, so they didn't really have a chance. In any case, 40 to 50% of patients responded. The counts came up, but it was the stem cells from the patient himself or herself that was reconstituting the bone marrow. So it must have been something about the ATG itself. And that was later recognized. This is the original report of how that happened. Now, at first, there was a lot of speculation and they didn't believe it. In the late 70s, more detailed experiments were done and it worked in 40, 50% of patients. Now, 40, 50% It's still not perfect. Okay, so how can we improve on this? We need to do something better, right? So then in the 80s, once they recognized that, hey, we have to do something about these T cells, and the ATG depleting T cells is not enough. What else can we do? Well, the ATG gets rid of 97, 98% of the T cells. But if we can find a medicine that can turn off T cells, that might be of benefit too. And that's when cyclosporin came in. It was then developed as a drug for patients that were getting solid organ transplants, like kidney transplants, heart transplants. So they said, well, we might as well try it in patients with aplastic anemia. And now we have two ways to attack the T cells. The ATG depletes the T cells, and the cyclosporin turns off whichever ones were not targeted by the ATG. And with this intervention, all of a sudden, 60 to 70% of patients responded. So you got an extra 20, 25% by adding cyclosporin and then giving responses in about 2/3 of patients. So the ATG is an infusion that you give in the hospital daily for 4 days. And then at the same time, you give cyclosporin pills. You take that at the original protocols, you take it for at least 6 months. And then after 6 months, the original protocol was to taper for another 6 months and stop. But when you stop cyclosporin, about 1/3 of patients relapse. Then you can treat them again and you rescue the majority of them. But each time you relapse, your stem cells take a hit. So it's still a research question what to do about, do you really need to taper cyclosporin? Is it better if you taper it even slower? I noticed that now the NIH has trials in which they're trying to find a different immunosuppressant other than cyclosporin to do maintenance long-term. Cyclosporin in the long-term can cause kidney problems. It can cause hypertension. So there are some issues about if you decide to put somebody cyclosporin for life. My practice, I tend to keep the patients on cyclosporin after 6 months at a low dose maintenance level. And the idea is if you keep levels around 100 nanograms per ml that are a low dose, they don't relapse. But when trials were done to try a different immune suppressants other than cyclosporin, it didn't work. They were too toxic to the marrow. But the idea now is that once you had a good response, maybe you can switch to those like sirolimus as a maintenance approach, but that's still on clinical trials. That stay tuned for that one. Other approaches to try to improve the responses were to add growth factors. So in the 80s, erythropoietin, a hormone that stimulates red cell production, and in the 90s, granulocyte colony stimulating growth factor, also known as Neupogen, brand name, can stimulate neutrophils. When they added erythropoietin or GCSF, the Neupogen, to ATG and cyclosporin, it didn't help. It didn't add anything. Now, interestingly, around the year 2010, NIH started a trial with a platelet growth factor, a pill form called L-Thrombopag, in patients that have relapsed after ATG and cyclosporin. And interestingly, as a single drug, it rescued many of these patients. So then it came up, okay, so we already tried erythropoietin, we already tried GCSF, let's try this one to upfront treatment. And surprisingly, this is the study as it was first reported in the year 2013. It worked and it cranked up responses up to 80%. And all of a sudden now we went from 40 to 50 with ATG alone to 66% with ATG and cyclosporine, and now getting in the 80% range when you add the platelet growth factor. This is a busy slide on the data, the phase 2 data from NIH on how it was first presented. The highlight is here. In the cohort that they gave L-Trombopac, brand name Promacta, from the beginning, in addition to ATG and cyclosporine, the response rate was 58% response rate according to the trial, but significant responses were up to 94% with a very high survival rate at 2 years. And not only that, but they noted that as opposed to in patients with ATG and cyclosporine, that they can get responses, but the marrow cellularity remains low. When you add L-Trombopac, the cellularity in the bone marrow also increases. I'm going to talk a little bit more about these response rates because that's nitty-gritty detail, and everybody defines responses in different ways. Now, this is this is more detail about the different cohorts. I'm going to skip that slide because I'm starting to run out of time. Here's the phase 3 data. This was a European study meant to corroborate the findings from the phase 2 study from NIH. And in this study, they have a comparator. In a phase 3 study, you have the standard of care and you have a new experimental drug. The control arm was ATG and cyclosporine by itself, and then the experimental arm, ATG and cyclosporine. And when you see that, they talk about response rate of 41% with the control arm and 68% with the new arm. Now, why the difference in all these numbers? Now, you have to understand what is considered a response. And there are responses that are defined by a trial, and there are responses that are significant for the individual patient. So what is a response? Oh, my blood counts normalized. Well, that's an excellent response. Well, what about if my blood counts improve? They're not quite normal, but they're still good. Shouldn't that count? Yes, it should count too. Well, what if my blood counts improve to the count that I no longer receive transfusions, but are still not that good? That's still important too. And I can go on. Counts improve to the point that I receive transfusions less frequently. That's good too. Oh, my platelet count improves. It's not necessarily normal, but they improve to the point that I no longer bleed. My white count, my neutrophil count improve to the point that I no longer get infections. It's not normal, but I'm not getting infections, so that's good too. Well, my blood counts don't improve that much, but I feel better. That's good too. And my blood counts improve to the point that I no longer need treatment. And that's something that is going to be reported different by different investigators. So as an example, I'm putting here the response criteria for the phase 3 study. This is the last one, the one that reported like 40% for ATG and cyclosporine and 60% more or less for the ATG, cyclosporine, and L-Trombopac, where these are very strict criteria because they wanted everything to be standardized. So to have a complete response, you have to have a hemoglobin greater than 10, an absolute neutrophil count greater than 1, and a platelet count greater than 100. And when you look at the bone marrow, there could not be any abnormalities. A partial response, hemoglobin greater than 8, with neutrophil count greater than 0.5, and a platelet count greater than 20. And then when they talk about responses, they combine complete and partial. And that's how those numbers were defined. And no response is anybody who didn't meet that criteria was not a responder. Well, so then what happens? Let's say, for example, that you have a patient that the neutrophil count went up, the platelet count went up, but the hemoglobin is 7.5. Oh, that patient in this study is considered a non-responder. But I'll take that response any day because a hemoglobin of 7.5, if your neutrophil count is good, you don't get infections. If your platelet count is up, you don't bleed. So you're a little anemic, so what? But it is those kind of patients that are not included in the phase 3 outcomes, but that's when they were saying in the phase 2 study, oh, but they have an overall response. Because at the end, if your neutrophil count comes up and you don't get any risk or infections, you do good because you can always get platelets or red cells. So it's really infections that get most of aplastic anemia patients. And if you get neutrophils and platelets, then you don't bleed and you don't get infections. So whenever you talk to your doctor, and you need to talk about, okay, so how is my response defined? And then you can see when you're trying to abstract numbers from, you ask Dr. Google and they start giving response rates in the literature, this is what you need to know. What were the exact nitty-gritty details? Now, the transplant doctors will tell you, okay, well, we normalize the counts, period. Your counts were bad, we give you new cells and everything is good. Yes, that's true. But not everybody's a candidate for a transplant. What happens if disease comes back or you do not respond? You can try ATG again and cyclosporin and L-Trombopac. There are 2 other drugs that are used. There is the alemtuzumab. It's a genetically engineered antibody that targets not only T cells, but also B cells. And there's a danazol, which is an anabolic steroid, think like testosterone. It's a growth factor, a non-specific growth factor that can also help the cells. The mechanism is by preventing aging. That's what they do, really, by stabilizing the telomeres at the tip of the chromosomes. I won't have much time to get into the telomere discussion today, but there was a bone marrow failure discussion earlier or later today that's the one that they'll talk a lot about, telomeres. Here's the response rate for alemtuzumab. It was up to 56% at 3 years. At 10 years, the response tended to burn out, and only 14% of patients maintain a response after response rate from alemtuzumab. On the danazol, about up to 1/3 of patients can respond. So the treatments for refractory or relapse disease are not perfect. What about survival? Because at the end, that's what counts. So this data is a little old. It's about 10 years old, but it just illustrates the points that the outcomes from matched siblings have improved significantly, and survivals 10 years ago was in the 80% range. Now they're approaching 90%. And people who are younger do better. So the transplants the medical therapies with immune suppression, as the ones that I'm describing today, they can have survivals, 10-year survivals in the 70 to 80% range. So the goal of medical therapies is to try to approach the transplant success, which now is in the 90%. The last, I just want to briefly talk about supportive care. Well, patients who have aplastic anemia often need red cells or platelet transfusions. If they get a lot of transfusions, they tend to accumulate iron, which can be toxic to the bone marrow and to the organs. So then you should try some type of chelation therapy. Sometimes responses are good, but not quite as good until you get rid of the excess iron. Therefore, the importance of chelation. If your counts are low, antifungals, antivirals, and antibacterial, specifically if your neutrophil count is less than 500, is important. PCP prophylaxis, a certain type of infections that happens on immune suppressed patients on cyclosporine, is advocated by NIH and others. It's usually a pentamidine monthly inhalation treatment. That was a lot of information. Questions?
Thank you, Dr. Rivera, for sharing the wonderful presentation. We'll start with a question online, and then we'll go to the different locations for in-person questions. Our first question online is it possible for someone to be diagnosed with aplastic anemia and still have a normal to high bone cellularity, 80% from a bone marrow biopsy results?
So if I hear correctly, the question is if you can get a normal cellularity after immune suppression and maintain it?
The question was, is it possible for someone to be diagnosed with aplastic anemia and still have a normal to high bone cellularity, 80% from bone marrow biopsy results?
No. The definition of aplastic anemia is that your cellularity has to be low. If your cellularity is high and your blood counts are low, you either have a myelodysplastic syndrome more likely, if the cells have something that resembles normalcy, or there are some patients that can have low counts but high cellularity if they have a PNH clone that fills the bone marrow and is making blood inefficiently.
Thank you, Dr. Rivera.
Questions here, Lee?
Thank you so much. Rochester, do you guys have some questions in the room?
No questions here either.
Okay.
Thank you. Do we have any questions here in Phoenix? Okay, I'm going to go back, and we have quite a bit of questions here, Dr. Rivera, online. The next question is, oops, sorry about that. I'm moving here. Can someone with aplastic anemia carry a child and give birth? What precautions should this individual take?
Well, if it's a woman who had aplastic anemia and is treated with immunosuppression, we discourage that woman to get pregnant because, as it turns out, sometimes a baby can be the trigger of aplastic anemia. Something about the baby tickles the T cells and they start attacking the bone marrow stem cells. So if you get successful treatment and you get pregnant again, that woman can be is putting herself at increased risk of getting aplastic anemia relapse. A man is different. In a man, there's no real concern in terms of that being a problem for the man himself. Yeah.
Thank you, Dr. Rivera. Our next question is, after ATG treatment for aplastic anemia, if a person goes on to develop PNH to the point where treatment is required, does this ever indicate future evolutions to MDS or AML are more likely to occur?
Right. So let me go back to the slide where we have the stem cells. And so we were talking about how the T lymphocytes attack the stem cells. And then treatment, successful treatment will mean let's turn off the T cells and then let the stem cells regenerate and normal blood production starts again. Now, remember that each time you get an immune attack like this, you have depleted greater than 90% of the stem cells. So if a PNH clone arises, it's not necessarily that there's still immune attack against the bone marrow. If a PNH clone arises, it's either there might not be enough normal stem cells behind. So the bone marrow is trying to form blood with whatever resources it has left, which might be a PNH stem cell remaining. There's also the possibility that the remaining stem cells are damaged somewhat, meaning like a clonal evolution to a myelodysplastic syndrome clone. And then those stem cells do not make blood efficiently. And again, the PNH cells are trying to make up for the lack of production for the normal stem cell or NDS type damage stem cell. So having that PNH clone indicates that the bone marrow, yes, is stressed, either because you have few stem cells or those other stem cells are damaged. So then that's risk for clonal evolution, and that patient is potentially at risk for, or a higher risk to develop into overt full-blown MDS or leukemia.
Thank you, Dr. Rivera. Our next question is there any anecdotal evidence showing an association between patients receiving mRNA vaccines and then developing severe aplastic anemia?
Yes. So there was a recent publication in British Journal of Hematology, and they look at 50 patients after COVID vaccines. First of all, the main purpose of the study was actually to see if they could mount responses to the COVID vaccine, and about 90% were able to mount a significant titer against the virus. In other words, the vaccines were protective in the majority of patients. In 3 out of 50 patients, there was a decline in the blood counts. So yes, the vaccine can decrease or affect stem cell production in a small percentage of patients. Now, you have to have a balance too, because the infection itself also can cause aplastic anemia. We just transplanted a young man who got COVID early this summer, and he had COVID, and that's what shut down his marrow. So as it stands today, the recommendation for aplastic anemia patient after immunosuppression is still the benefits probably outweigh the risk, because if they get full-blown COVID, that's a problem, and that's potentially worse.
Thank you, Dr. Rivera. Our next question is, can antibiotics affect platelets? And for what reason would a patient with aplastic anemia use antibiotics?
Right. You have to look at the side effect profile of the particular antibiotic that you're getting. For example, Bactrim is usually avoided in patients with aplastic anemia because Bactrim can be harsh on the marrow. So when we were talking about the prevention of the pulmonary infection like PCP, that's why we use inhaled pentamidine rather than Bactrim, which is the common first-line antibiotic for PCP in other patient population. So in general terms, every medicine to a greater or lesser extent can have a side effect. So you just look at the side effect profile of the particular antibiotic and try to minimize use of antibiotics that can affect the blood counts.
Thank you, Dr. Rivera. Our next question is, can you talk about the slow weaning protocol for patients who are using cyclosporine for treatment of aplastic anemia?
Yes. So the original protocols, as the protocols from NIH were developed in the 90s, were to treat for cyclosporine for a total of 6 months and then taper cyclosporine for another 6 months. So by a year, the patient will be off cyclosporine. But then they noted that 1 out of 3 patients relapse, which is not good. And yes, you can rescue the majority of these patients, but going through ATG again is not pleasant, as many of you know. So then the latest protocols have been keeping cyclosporine up to 2 years at therapeutic dose and then start tapering then, but that can be harsh on the kidneys. There's still not a good standard. As I mentioned in my practice, what I do is that I keep them in a therapeutic range between cyclosporine levels at 200 to 400 nanograms per ml for 6 months. And then over 6 months, I gradually bring down the dose of cyclosporine with a target level of 100 nanograms per ml. I keep them there, but that's just a Rivera protocol. That's not a standardized universal protocol. And as I mentioned, the Heart, Lung, and Blood Institute is looking into this, and they now have a clinical trial. After a period of time on cyclosporine, they want to see, I think it's sirolimus, the one that they are using. So the idea is that when they use sirolimus up front with ATG and cyclosporine, with ATG, sirolimus and ATG, it wasn't good because sirolimus can be toxic to the marrow. So the responses were not better than ATG and cyclosporine. But the idea is that after a year or so, now all of a sudden you have plenty of stem cells and bone marrow progenitors. So you might get by with a drug that is a little toxic to the marrow, but you already have a bunch of cells, and avoid the kidney damaging effects of the cyclosporine, avoid the hypertension, avoid the predisposition for seizures, those kind of things. So I hope that answered the question.
Thank you, Dr. Rivera. We have one last question. The question says, my daughter was treated in the 90s. She had ATG and cyclosporine. She's been in partial remission, but her platelets have never really recovered. They're running in the 60,000s, and her other counts are trending down. Any thoughts on what may be having and what would be our next steps?
Right. So this is what we were talking about, the what constitutes a response. So and it was a daughter, so I presume this person must be in the 50s. If he was treated 30 years ago, possibly treated as a young adult, 40s or 50. So if the platelet count is 60 and the other counts are dropping, it's possible that the stem cell pool is burning out. It's possible that the patient might be developed chromosome abnormalities, some damage in the DNA to the stem cells. And that's why preferentially when you have a young person, you younger than 40, you tend to recommend transplant if a suitable donor is available rather than immune therapies. Now, there may not have been a donor available then, but there might be a donor available now. And now the technology of transplant is getting better to the point that they do haploidentical, meaning half match transplants with almost the same success or better well, no, almost the same success, not necessarily better, but as a fully matched transplant. Without knowing the severity of the other counts, it's hard to make a strong statement if this patient should consider additional treatment or transplant. A platelet count of 60 keeps you pretty much out of trouble from bleeding. So the platelet count in itself is not a problem. It's the other counts that, particularly the neutrophil count, the absolute neutrophil count is getting lower than 0.5. That's when you start getting an increased risk of infections, and that's when you need to start considering other treatments.
Thank you so much, Dr. Rivera, for sharing your time and your expertise with all of us today. This session will be available on the conference platform within the next hour by just accessing the session and clicking replay. It will also be available on our website within the next few weeks. If you have any additional questions, you can send it to us at any time in 3 ways. You can email help@aamds.org. Call our helpline at 800-747-2820, extension 2, or you can submit your question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 40 years. This concludes our session, and the next session, educational sessions, will start in approximately 15 minutes.
My pleasure.
Hi, everybody. So we're going to go to break till 2:45. In this room, at 2:45, we're going to have transplant with aplastic anemia and MDS. And in the room right across the hall, we're going to have PNH and non-transplant therapies in room